came to a different clinic for refractive evaluation, no history of previous eye surgery, currently wears glasses, contact lenses. You can see manifest, cyclo, a little bit of difference there, lot of SIL. When you look at his white to white ACDs, PACs, this is going to be a great EVO patient, essentially. And so that's what the surgeon chose. They did the left eye first, and they were planning to do the right eye a week later. One of the things that I really respected reading through the surgeon's notes is they built in there, looking at that, so they're like, we're probably going to want to do LASIK or PRK after we do the EVO for any residual astigmatism, if that needs to be cleaned up. So they had already planted that seed in the patient's mind. So game plan, we'll get that left eye done first with EVO, then we'll do the right eye a week later. We'll come back down the road, polish up any residual astigmatism with LASIK or PRK.
I have a question right there. Why would you promise that to the patient? That's with the rule, and at most they're going to have like a half diopter, looks like, right?
I think it's a good question. I think the surgeon in this case was trying to plant the seed to say, if we can't nail this prescription for whatever reason,
Yeah.
we could consider additional refractive options down the road.
That sounds like treating the doctor, not the patient, in my opinion.
I don't know, man. On these patients, so you want to set the expectations, you know, like, yeah, we might need to do a laser touch up. We'll see. Let's see how the first eye goes. I mean, I think it's all about delivery on how that message. The other thing you have to consider is like the incisions for ICL here, and you have your, it is with the roll, but when you make your incisions, it's going to increase the SIL. So I've seen this where you do a spherical ICL that's with the roll, a little bit of with the roll SIL, and then end up like half a diopter more. So I think that, again, it's all about how we communicate with patients, but not a bad strategy if you say it softly and not something that they get so fixated like, okay, I need the next step.
Yeah.
I also think a patient with a complex prescription like that is going to be used to their whole life having to order their glasses or their specialty contact lenses and wait ages for that. So I think maybe giving them that little bit of like an asterisk of like very softly, you may need, I don't think it's a bad thing.
It's nice to have expectations. You guys have heard this phrase before. If you talk about it before surgery, it's not a complication, it's an expectation. And so I think that was really good for this patient's personality. There's clearly a reason the surgeon put that in the note. And I think it was because of the patient's personality. And I think the surgeon knew that this could have some challenges. So 1 day post-op, left eye's been done, uncorrected vision is 2200, pinhole to 2040. I have the benefit of seeing lots of EVO 1 days, and this is very unusual. This is a very unusual uncorrected vision. So the surgeon who did the procedure noticed that the lens had rotated, and they wanted to exchange the EVO. They were going to go with a 13.7. So patient came back. This is 1 day post-op exchange. You can see the vision's improved 20/40. But when you look at the MR, still pretty unusual there. The surgeon said the lens was stable. The visual quality was a little bit limited because of the residual. Patient comes back in a month. And this is where the patient had gone in for the initial surgery, gone in for, in the patient's perspective, a revision to have that rotated and exchanged. And so the patient was losing a little bit of confidence in the experience overall. So he came to our office and said, what are my options? So he's living this life where his right eye, he's got a contact in, so he's making it through. His left eye, he feels like it's just fuzzy and out of focus at all ranges. And so you can see PACs, ACD there, white to white. And I'm like, let's just take a look at this lens. So both of these images are your left eye, and you can see that vault. We've got 22 microns between the EVO and the cornea there. What's the slimmest vault you guys have seen?
You mean between the EVO and the crystalline lens, right? But
yeah.
I mean, I don't get too bothered by a small vault. What concerns me though is if that lens is undersized and it rotates.
I'm worried at 22. I think even around 50, I start to think, traditionally, like with the legacy ICLs, we used to worry a lot more about all kinds of different things. You'd have to treat the vault. Now we treat, the things that the vault causes. And if traditionally, or I guess more habitually, if there's no issue, we don't need to treat it. But I think getting into those really low numbers, that's a ticking time bomb for me. under 50.
We have an ICL that was originally picked as a 13.2, and the reason a 13.2 was picked, even though you had this giant eye with a white to white of, if you go back one more, what was the white to white? It's ginormous. 13.2. Okay, so that's like, you're like, okay, that's gonna be a 13.7. But like the cardinal rule is like, gosh, don't put a 13.7 in initially. But you know, if you look at what OCO says, you know, and I think probably Star would say like, oh, you should put 13.7 in because that's what OCO says to do. Now, when you put this in, what's really interesting is if you go, you put this, okay, let's say, can you go back one slide, Becky? You put this 13.7 in, okay, well, they put 13.2 in and then hold on, go one forward. Yes, okay, so you have this lens that's rotating, which probably has, the fact that it says 150 microns volts, like I don't trust that.
I don't either.
Yeah, I don't trust that because the next one has 200. If you go to the next one, when you rotate, it has 200, but yet you got 22 microns, and the vault doesn't change like that over time. So what's interesting here, though, is that you have an MRX of +1, -2, access 15, and then this is at the 1-day post-op, and then when you go to the next slide, you have here, however long this is, 2 months later, the prescription is at +150, -2, access 20. To me, even though that's 22, that is 22 microns of vault, the one thing that I'm looking at here is like, that's kind of interesting because if you would think the lens is rotating, that prescription would change. And here we have a case where we have the same prescription at the 1 day compared to the 2 months later. So in my mind, my first question is like, was it just put at the wrong axis? Question number one. Question number two, is it still spinning? And then question number three is like, what do we do here? Like, what do we think is best for this patient? Because I don't know what the packs are, but I feel like you basically have three options here. Option number one is you could leave the lens there. I've seen vaults of like 0, 5, 7, 8, 9, 10, 11, whatever microns. And ultimately, I think because now we have that central port there, for me, as long as the patient is doing fine, we're just going to watch it. It used to be we were worried about cataracts. Now we just kind of watch it. And I think these patients need to be monitored. But again, because the aqueous is going through and bathing the crystalline lens, I haven't seen that cause problems. But maybe we'll be wrong over time, even though we have the 5-year data from Packer saying that didn't really cause any problems. So option number one is you could just leave it and the patient could wear contacts or glasses. Option number two is you could rotate it. If the prescription's been stable for 2 months, what if we try just to go in real quick and rotate it, and then let's see what happens, which is something that might be at the top of my list. And then option number three that you have is you could take the ICL out and put in a spherical ICL, which would again have a low vault, and then you could come back and do LASIK on top just for the sill.
I would be curious about, I mean, you'd want to do an investigative dive into the pre-op planning here. I think there's sources for human error also that maybe we're looking too closely into, what's happening on the back end, but were the numbers just typed in correctly?
The thing when you see like this prescription of like +150 -2, like this mixed MRX, like for me, that's like when the spherical equivalent is pretty close to 0, it's like, or what you're aiming for, it's like, okay, we had it on the money. We're just not at the right axis, just like a toric IOL after surgery.
Right. I mean, was the axis just typed in incorrectly?
We internally had a lot of questions about the vault too. I'm usually in a comfort zone around 50, and this was a little less than that. And so the surgeon was like, you could leave it, you could take it out, had all of the same thoughts you did, Bobby. But the key question was, how is the patient's confidence? At this point, not great. And so, I mean, we covered all of these different recommendations. Ultimately, I am waiting to hear what the
What I would
patient
not
wants
do
to
is do LASIK over the current ICL because
Right.
it has a low,
Yep.
even though it's stable, because it has a low vault, it's more likely to spin. So for me, if there was only one that I would not choose, it would be LASIK over a low vaulted ICL. That's
Yeah, 100%. Yeah, that suction would cause some problems. And you could do PRK, but at that point, I don't know that the patient would be
well, it's just a matter of if it rotates, right? Like if it
Right.
rotates, then that prescription is going to be off that you just ablated on the cornea.
So I'm pretty confident he's going to take it out and go back to contact lenses. He's just been kind of frustrated with the surgical experience, which I respect in this point. But Nick, you brought up a lot of good points. Human error, the element of human that we all do, making sure that we're doing those measure twice, cut once measurements, that type of thing. It plays into all of these surgical conversations and the overall
You see
patient
this patient and
confidence.
you're like, man, is this lens rotating? Like, how do I do the math to know? because I had an optometrist recently text me like, oh, we have this giant prescription on the 1-day post-op and it was mixed. And it's like, okay, this lens was rotated. And it's because the surgeon put it like an IOL instead of like an ICL. They put it at the steep axis instead of where the plan said to put it. So I think that's a really interesting point. These ICLs come specifically made. Don't put it at the steep axis, right? You're putting it on whatever the paper, wherever you did your calculations, where it goes. But is there any resource that you guys use? I use fixmystigmatism.com. I'm trying to see if that's still the website. Astigmatismfix.com. Do you guys have anything specific you guys use?
For do you
That's
use
the one.
that for ICLs, Bobby?
Yeah, it has now an ICL calculator on there.
I've never actually used it for that. I mean, we've had so few of these really be an issue, but for IOLs, we use Astigmatism Fix. But actually, Barrett RX is awesome for that because it'll tell you sometimes it's better to rotate and sometimes it's better to exchange altogether.
Right. And you're talking about for IOLs or are you talking about for ICLs?
Yeah, yeah.
Yeah. So same holds true with the ICL. So if you're ever trying to figure out like, well, did we order the right lens? Was it a calculation like Nick said, or do we just rotate it? That helps you with your calculations. And so that's a really good resource for everybody listening.